I have the pleasure to announce the next speaker after this very impressive presentation of a life-changing presentation. So I would like to introduce Professor John Bridgewater from the University College Hospital in London, who will give us a presentation on targeted therapies, immunotherapies, and what are they, how are they different, and clinical trials. John is preparing itself to come up. Very good. And I hope we have a presentation of his. Yes, we have. Thank you so much. Please go ahead, John.
Great. Thanks very much for the invite, Helen, and the AMMF. Always a great pleasure to come here. This is always a special meeting because you, the patients, your carers, you're here, and that really brings the message home about what we do, why we do it, and just underlines what we need to focus on. And doctors of various types, researchers, love their own little subject, can spend all day talking about it, but actually just bringing it back to the patient is a very valuable thing to do. So thanks very much, everybody. And here's an introduction, somewhat less beautiful than Katie, much more prosaic, but I hope it ticks the box. This is about therapies, new therapies for cholangiocarcinoma. So the two things in the title, targeted therapies and immunotherapy. Targeted therapies are exactly that. Targeted is directed at a known alteration in the cancer. Most of those alterations, and you have to do that by doing a test. Most of those alterations are genomic. They are errors in the coding. They are the errors that make the cells go bad. They're the errors that drive the cancer. They are by no means all the errors, and only a few cancer cells will be able to find these genomic things. That's because we're probably not very good at testing for the others, and gradually we'll begin to learn to test for the non-genomic alterations that we can ultimately target as well. The other bit of the talk is about immunotherapy, and this is essentially a process to help your own immune system, the body's immune system, which after all fights off multiple infections and foreign materials and foreign things the whole time, help your immune system fight the cancer. Your cancer, or any cancer by definition, has pretty much evaded your own immune system. It's various cunning ways of getting around that. And the immunotherapy is to try and turn the clock back on that, to try and make it possible, give your own immune system the chance to attack the cancer. So those are the two topics that we're going to go on about. Let's do the genomic bit first. So cancer is many people said actually this is not entirely true. It's more than a genetic disease, but it's mostly they think a genetic disease. So this is a cell, and a cell could be anywhere. It could be in your skin, in your bowel, in your bile duct. And the way that cells work is that stimuli from the outside, so stuff from the outside, the little round dot here, here we go, little round dot, comes to a receptor on the cell surface and then signals through a number of intermediates, signals to the nucleus where all the DNA is, and that either stays the same, divides, moves, changes. In cancer, most of the time the receptor or something of that order goes wrong and the signaling goes haywire, and you have inordinately large amounts of signaling to the cancer cell, and that's what drives your cancer. And so the intention of targeted therapy is to block that signaling, and in some cases that works very well. In other cases it's less good, but that is the intention. It doesn't always work because of this. If you have, I've demonstrated A goes to B goes to C in one straight line. Of course, our biology is not like that. There are multiple lines going to multiple places. This is, in fact, the Tokyo Metro map. But you can see that if you have one blockage here, there are many, many ways of getting around that. So that's one of the problems that we have, and that is the common problem with targeted therapies. What's the latest manifestation of this? Well, this is our latest manifestation of it. This is our current lead academic study funded by CRUK, the ABC10 study, where people with biliary tract cancer, so cholangiocarcinoma and gallbladder cancer, go for the testing. It transpires, now that we're about 200 patients in, that the testing turns out to be way the more important bit of it and way the more interesting bit of it. Two tests. We do two tests, both on the biopsy or the resection specimen and the blood. And surprise, surprise, two tests are better than one. And it's telling us currently that about almost 40% of people are able to have one of these targeted therapies, one of these new drugs that we have at the bottom here. And so that's going really well, and we will probably finish about a year ahead of time. The other spin-off that's incredibly heartening is that, as well as the core protocol, which I've just described, so this green stuff on the side here, there are now going to be multiple spin-offs in terms of new targets. IDH2, the poor sister of IDH1, BAP1, a type of BRCA abnormality, the dreaded RAS gene, responsible for about 20% of these cancers, but multiple other types of cancer. So spin-offs of all of these are flying off the main ABC10 study. This is incredibly encouraging, and gives people with biliary tract cancer more options. Immunotherapy. So in the same way that cancer is a genetic disease, cancer is an immunological disease. And a bit more difficult to explain in 3 minutes than targeted therapies. But essentially, your cancer cell is normally recognized by your T cell, so that's a lymphocyte, so that's a white cell, and the T cell goes about killing the cancer cell through this process. The T helper cell recognizes the cancer cell through the antigen and something called major histocompatibility complex, and it recognizes the cancer cell and kills it. This process is blocked by this parallel set of receptors here, PDL1 and PD1, programmed death receptor 1 and programmed death receptor ligand 1. There are others. I'm simplifying it somewhat. Or immunotherapy of various types is trying to reverse that process. So here. One of the main things that people do is to try and block PDL1 and the drug durvalumab, which has been approved by NICE last year, is one of those. There are other ways of trying to do it. You can try and use vaccines to influence primarily the presentation of novel antigens. And then you can use cellular therapy. So you can make a whole load of T cells that go in there and kill this thing. You can isolate the single T cell that's going to do the job, bring it out of the body, make a whole pile of them, put them back in. So those are cellular therapies. CAR T is probably, I think, called CAR T therapy is probably the most advanced of those, and that's the other way of doing it. But this is an evolving, massively complicated treatment process, but probably the next thing to aim for beyond targeted therapies, immune therapies, and then there'll be others. There'll be others to follow that, epigenetic therapies, other therapies of other types, protein therapies. There's no stopping it. So yes, this is just to demonstrate that durvalumab is in fact approved now for people with biliary tract cancer, and we think it acts in the way that was indicated earlier. Doesn't really work, or we don't have much evidence that it works after the first line, after the first treatment. But of course, people are now adding different things to it. So as well as the PD-L1, they're adding other similar PD-L1 type things to it. There's all sorts of them. There's one called OX40. There's one called TIGIT. There's a whole load of these, and people are now adding these in to see whether it'll work. So it's an area of immense activity. A biomarker is coming. So what do I mean by that? Well, you give everybody durvalumab, and only a relatively modest number of them benefit. Those that benefit can benefit hugely. So it's a very valuable addition. But we can't, at the moment, easily tell who's going to benefit and who's not going to benefit. And so for that, we need a thing called the biomarker that differentiates it. So if you have this biomarker, you do respond, and if you don't have the biomarker, you don't respond, roughly speaking. It's never that neat, but roughly speaking, that's the case. And the biomarker is coming. There's a whole load of increasingly sophisticated tests to look for the type of T cells that you need in your cancer. It's not going to be possible to, I hope it'll boil down to a simple test. I'm slightly afraid it's going to be a complicated test every time. But it is coming and will help us hugely in terms of making sure the right patient gets the right treatment. So, in summary, and I think I forget whether we have any time. Do we do questions now or later, Heinz? Later, okay. So in summary, targeted and immune therapies are both active in biliary tract cancer. Targeted therapies are probably slightly more advanced and probably have a greater impact, but they've been around for longer, and so you'd sort of expect that. It's not an easy thing to do. You can see that immune therapy is a complicated business. The testing for the targeted therapies is a painstaking, somewhat. You need to be extremely careful about the test that you get, what it means. Somebody has to understand it, what you do about it, what you do about the next test. This is not a it's not a simple tick box exercise. You do need to understand the ins and outs of it, and currently not all health professionals out there have that. I'm not blaming them in any way, but currently not all of them have that level of knowledge. And if you have time, well, I'll probably show at some stage another slide saying, looking at the gaps in terms of that knowledge. It's a big topic of conversation. I think I'm having a discussion with one of our patient representatives tomorrow about this exact subject, tomorrow evening in the thing. Yes, thank you. Yeah. So Andrea, is Andrea here yet? Andrea and I are speaking about this exact subject tomorrow lunchtime. Be there. So the research is absolutely key in terms of developing this more. We need more people like me. We need more support for the AMMF. We need more support for research in this area generally. You can see there's a lot more to be done. These are all the people that support me. Thank you very much for listening.